I'm Dr. Sharda Jain. I'm the Director of Life Care IVF. I'm also the Secretary General of Delhi Gynecologist Forum and the teaching program coordinator of Delhi Gynecologist Forum. I'm going to speak about thin endometrium and infertility. Whenever the cycle fails, there are many questions, in fact, lot of questions by the patient, by her relatives, and there are no clear answers. You'll be surprised to know that a monthly fecundity of a woman is 20 to 25% per cycle. But in IVF, 60% of IVF cycles do not end up in pregnancy. For a good doctor, it's very important to find out what went wrong. What can be changed? The egg can be changed, the sperms can be changed, the uterus can be changed, and the clinic can be changed. The treatment of infertility can be a roller coaster ride. The eggs are important for 80% of the success. Good gametes give good pregnancy. The sperms are responsible for 10% and the uterus is responsible for 10% of the failures. Hard facts. Healthy seed just is not enough to give you a healthy plant unless it is grown on the fertile soil. Similarly, healthy embryo need receptive endometrium for successful implantation. The USP of the endometrium is that human endometrium is highly regenerative tissue. Every month it is shed off, every month it grows. Then the question is why fertility and implantation in human beings is so low. Lately there has been interest in endometrial function and endometrial receptivity. Today we have improved all aspects of IVF, but still the average pregnancy rate is not more than 40 to 50%. We are finding it very difficult to further increase it. The bottleneck is the process of implantation. We know very little about it. This is the bottleneck. Implantation is the most vital part of reproduction. Unfortunately, it is least understood. In fact, it can be regarded as a rate limiting step in reproduction. So required preparation for the endometrium is directed towards window of implantation. This window of implantation is 7 days after the ovulation. So if you find that the ovulation has taken place, then if it has taken place on day 14, then the window of implantation is 20th, 21st, 22nd, 23rd, 24th. These 4-5 days. The window of implantation starts 6 to 7 days after ovulation when the secretory activity of the glands is at its maximum, and at this time the endometrium is best prepared for implantation of blastocyst, that is on day 20th and day 21st. The endometrial receptivity during the window of implantation depends upon the endometrial thickness, the endometrial pattern, the endometrial and the subendometrial blood flow. Endometrium is said to be hostile for the embryo except this window of implantation. The clinical importance of endometrium is there for successful implantation depends upon close dialogue between the blastocyst and the endometrium. Thin endometrium may be because of the endometrial resistance to circulating estrogen, the reduced blood flow to the endometrium, overexposure to testosterone, and permanent damage to the basal endometrium. Permanent damage to the basal endometrium may occur due to severe endometritis, which occurs because of tuberculosis or because of vigorous curettage following abortion. Persistent thin endometrium should always be evaluated for latent tuberculosis, as incidence of genital tuberculosis is very high in India, anything between 35 to 50%. For practical purposes, completely damaged basal endometrium cannot be regenerated. For endometrial evaluation, we require functional biochemical markers, the histology, the assessment by ultrasound, that is 2D, 3D, Doppler and hysteroscopy. I did mention to you that we did a workshop where we called 20 patients of our IVF failures, and we did hysteroscopy with Osama Saki, and we found not a single patient the hysteroscopy was normal, showing thereby there was something, whether it's a polyp, whether it's a T-shaped cavity, whether it's some adhesions, which was cause of the previous failure. Coming to endometrial evaluation. Transvaginal sonography is a very simple test, very rapid, non-invasive means of assessing endometrium. And the thickest part of the endometrium should be measured. Endometrial thickness, main advantage of measuring endometrial thickness lies in a very high negative predictive value. Some authors suggest that the endometrium 6 or less is associated with 100% negative results, and people like us say that 7 millimeter endometrium or more is essential for pregnancy. Another thing, high uterine flow rate is associated with a positive pregnancy. So this particular Doppler should be put, and we can exactly know how healthy the endometrium is. So the endometrium implantation, to sum up, occurs between 8 to 14 years. If it is less than 7 or more than 16, that is unlikely to have pregnancy. Now, one of the most challenging problems faced in the treatment today of infertility is thin endometrium. But now we have clear-cut remedies available which we can use. Clear association between endometrial growth and the circulating estrogen and progesterone is known. These hormones bind the intracellular receptors, and resulting protein upregulate or downregulate the genes which influence the implantation. Today, the number of drugs and the methods are available to improve estrogen levels in the endometrium and increase the blood supply to the basal endometrium. Alternative drugs to clomiphene are, you all know, that letrozole and tamoxifen, and that's really not the talk today. We can definitely take it as an alternative. Addition of estrogen is the next most logical step to improve the thin endometrium. One should be very clear, if the pregnancy will not occur if the PI of the uterus is more than 3. The famous meta-analysis on estrogen use shows that you have to use estrogen valerate, and appropriate development of endometrium will take place in good 70 to 80% of cases. The dose, the regime, the type of estrogens used very widely with little consensus among doctors. High dose of vitamin D is very important. 600 milligram, you can give it 200 milligram 3 times a day. orally significantly improves the endometrial thickness. Oral L-arginine, that is in the dose of 6 grams per day, again improves the result of the endometrium. Sildenafil improves uterine blood flow. The dose has to be 25 milligram vaginally 4 times a day, will do a great job. Pentoxyphylline, again the results are inconclusive. Earlier we used to use it. Micronized low dose aspirin, the last word has still not come. So till that time, no conclusive results. Nitroglycerin patch is also found to improve the uterine blood circulation, but it has no consistent results. Lifestyle changes are very important. Give up smoking, give up alcohol, and improve your BMI. All these will improve the vascularity of the endometrium. Coming to the new modality, granulocyte colony stimulating factor, GCSF. We found it has a promise, and this was first reported by Norbert Gleischer in 2011, and since the particular time many people, including myself, we are happy with these results. This particular slide is showing the original paper which was on the success of DHEA. Now, how do we use it? This granulocyte colony stimulating count is available as 1 ml. 0.3 ml we put intrauterine 2 days before the transfer, 2 or 3 days before the transfer. And at our place we give exactly 12 hours before the HCG trigger. And 0.7 ml we give it subcutaneously. We find estrogen valerate and this GCSF does wonders. Sometimes we require more than 1 dose. These are the various results which have been reported about the glory of the GCSF for thin endometrium. The other things like low molecular weight heparin, corticosteroid, intravenous immunoglobulins, intralipids, again, they are not effective and hence not advocated at this time. Neuromuscular electrical stimulation, that's again, people are working on it. Again, no final answer has come. Endometrial scratch is another wonderful thing. It is said that in a previous cycle on day 21, you should do this particular test, and both cumulative pregnancy rate and the live birth rate have found to be doubled. So now almost every gynecologist uses this in her practice. Now, what is the rationale for endometrial scratch? It induces desudalization of endometrium, releases cytokinins, growth factor and macrophages, and endometrial injury improves blood supply, and healing promotes inflammation necessary for implantation. When to do it, I have just now said it should not be done in the same cycle, it should be done in the previous cycle. What holds for tomorrow? Endometrial reconstruction with autologous stem cell therapy in a freshly prepared platelet-rich plasma again does wonders. If you find that the estrogen valerate and GCSF does not help your patient, then you can use this simple therapy. Very easy to do it. We teach all our patients, all our doctors who are coming for infertility and IVF training, we teach them, and this is very simple thing which we can use and day out practice. It's a breakthrough in reproduction. The possible mechanism it has, it evokes favorable inflammatory reaction producing cytokinins and secretes proteases which regulates endometrial function and thus improves implantation. Ideal candidate for stem cell therapy are patients with persistent thin endometrium and repeated implantation failure, treated patient of tuberculosis with thin endometrium and Asherman grade 3. 2017, we had a data which we compiled, and we had used 16 cases. Out of that, 5 had become pregnant, and since that particular time, now we have incorporated in our teaching program, and we find this is something which is very promising. So to conclude, select the best seed, prepare the best soil, plant at the appropriate time. Taking a different approaches achieves a pregnancy in many cases that failed repeatedly. To conclude, soil thickness of 7 millimeter is must for achieving pregnancy. GCSF, endometrial scratch, and endometrial cell therapy from PRP has a promising future. Thank you very much.